So, hello everybody. First of all, I would like to say thank you for the possibility to be part of this meeting. Topic for me today is the full-endoscopic foraminal technique. When we're talking about full-endoscopic techniques, we all know this is first of all a technique for decompression, and we developed in the last, more than the last 20 years, a lot of technical things, but also approaches to all parts of the spine. And I will talk about the foraminal approach. We divide the foraminal approach into a transforaminal, intra and extraforaminal one, and now I will hint at some specialties for these three parts of the foraminal approach. When we're talking about the foraminal approach, we know we are working the caudal part of the neuroforamen. The nerve is cranial and anterior. We are working with a 25-degree optical system. That means our intraoperative viewing is from anterior to posterior. Since more than 20 years, we are working with a lateral foraminal approach, because when we're using a posterolateral approach, we know the facet is a kind of fulcrum or hypomothlon which pushes the sleeve towards anterior, and lateral, that means our working area changes into the disc and not in the ventral epidural space, and we have a higher risk to damage the exiting nerve. So we are not measuring centimeters from the midline to mark our entry point, but we are using anatomical landmarks like in the Larusian position, the posterior line of the facets, to start with our approach. And the main goal is to reach the epidural space directly. Of course, we cannot do that in every level. L5 is one, we have the iliac crest to respect, and in higher cranial levels of the lumbar spine, we have to respect the visceral organs, but in these cases you have much more mobility due to the larger length of the pedicle. Is the neuroforamen larger and larger as higher you go in the lumbar spine. So we can choose a more posterolateral approach and have enough mobility to enter the spinal canal. So let's first have a closer look to the transforaminal approach. You know it's a blunt dilator technique. And we are passing the foraminal area and the exiting nerve root without direct visualization. Example for that, we insert the endoscope and then we see the structures in front of us. We see the horizontal structures. That's the posterior ligament and the annulus. Here's the entry to the disc space. And to the dorsal aspect, you find the herniation pressing the epidural fat and the structures to the dorsal aspect. There are no free floating structures, so we resect the herniated material, and after resection of the herniated material, we will see the beginning of the floating of the structures. So that is not the dura, that's the elongated ligament, but you see it as already pulsation here. That's the entrance to the epidural space. So it's not necessary to resect the elongated ligament. We do this here just for demonstration to show that we see the dura here of the neurostructure after resection of the elongated ligament. But what we have to have is the free pulsating structures inside the spinal canal after finishing our decompression of the disc herniation. So when we're doing an intraforaminal approach, we have to orientate ourselves in the foramen. Maybe we have a pathology located inside the spinal canal and we want to go through the foramen to this pathology, but we have a very small foramen, so we cannot directly reach it with a transforaminal approach. So we are starting inside the foramen, and then we have to identify the surrounding lead structures. That's the pedicle, the SAP, the disc, and then the entrance to the foramen. And when we're working in this area and we pull back the sleeve, it is possible that the exiting nerve root is directly in front of the sleeve. Then we have to pull back the sleeve a little bit, lift it to the posterior aspect, and push it forward to go again the exiting nerve root. When we have done an intraforaminal approach, we have then the possibility to work transforaminal. That means with or without bone resection, we are starting definitively outside of the disc. We protect the annulus and the end plates, and then we pass the foramen under visual control. You may have heard about the safe zone, which exists, Komp and triangle, to our mind, a safe zone never exists there when you're not able to identify clearly the structures in the preoperative MRI. If you have, for example, foraminal herniation, if you have a stenotic situation, and then we have a high risk if we are doing this and believing at the safe zone. So we have a high risk to have a nerve injury, and that's a reason to do an extraforaminal approach. That means our approach starts outside of the foramen at the bony junction of the pedicle and the ascending facet. And when we do so, starting there, we have the possibility to work again transforaminal with or without bone resection. When we do it like that, we are starting definitely outside of the disc. We protect the annulus and the end plates, and we have a reduced risk of exiting nerve injury, and we pass the foramen again on a complete visualization. When we want to increase mobility towards cranial, caudal, or posterior, we can pull back the sleeve a little bit inside the foramen. We always have to make sure that the exiting nerve root is not slipping in our pathway. And then we have the possibility to widen the foramen under visual control in the direction that we need. About 50% of the herniations are located in the intra or extraforaminal area. And for a conventional operation, you do a paramedian approach. When you do this full endoscopically, you have two possibilities. When there's no limitation for a transforaminal approach, you can start transforaminally. That means passing the structures blindly, and then insert the endoscope, pull back the sleeve, and move the sleeve towards cranium, move the endoscope, rotate the endoscope towards cranium, and resect the herniation. Example for that, L3-4 on the left side. So we pull back the sleeve. Left side is cranial, right side is caudal. This is dorsal, and this is anterior. So that's the SAP here. That's the disc space. Then we go to the cranial aspect. We rotate the cannula to the cranial aspect. Here we see the beginning of the exiting nerve root, and here the beginning of the herniated material. That's the entry here to the spinal canal. So again, exiting nerve root, herniated material, which presses the structures to the dorsal aspect. And then we resect step by step the material and the herniated material, which follows the exiting nerve root, in this case in the axilla area. So exiting nerve root and SAP. So the other possibilities, we start extra or intraforaminally, and then we shift the nerve to the cranial aspect, opening of the sleeve to the caudal aspect. So we use the Bharath operation as a kind of nerve hook to mobilize the neurostructure. Example for that, here we are using an extraforaminal approach. First thing what we have to do is to identify here the pedicle, the junction of the pedicle and the ascending facet, the SAP. And then we have to prepare the disc and the caudal part of the foramen. Then we go to the cranial part of the foramen, find the herniation, find the exiting nerve root, and prepare everything there. So now resection of the herniated material. Then we lift up the L4 nerve root here to get underneath the L4 nerve root. Again here the pieces which are going in direction to the spinal canal, SAP, and the L4 nerve root after decompression. And here the entry to the spinal canal. Here vertebral body, and the way to the disc here. And here the exiting nerve root. So why are we working again in this intra-extraforaminal area with the lateral approach? Well, we have the possibility to work underneath the new structure without squeezing it. When you use a posterolateral approach, your orientation is like that you press the exiting nerve roots towards the cranial pedicle, and then you have a higher risk to damage the exiting nerve root. So when we look at these foraminal approaches, trans, intra, and extra, you may say, oh, these are only small differences. That's right. But for us, they are really relevant for our daily practice. And it is quite easy to do a transfemoral approach because everything is fixed when you insert the endoscope, and it's much more demanding to do an intra or extrafemoral approach. So these are, especially these approaches for more experts after starting with a transfemoral approach. So algorithm for lumbar disc herniation: first you have to identify the pathology, then you have to identify or clearly access criteria, and if this fitting together, we can choose a foraminal technique. Only in about 35% of the cases of our daily practice, practice can be done with a foraminal technique. The rest is done interlaminar. But whenever it is possible, we try to choose the foraminal approach because we think it's the least traumatic approach to the lumbar spine, and it's the approach of first choice for us. So what's with foraminal approach in stenosis, especially lateral stenosis? We divide lateral stenosis into foraminal and recess stenosis. Mainly we're talking again about radicular symptoms. When we're talking about foraminal approaches in stenosis, we always have to identify where's the problem. Is the problem in the intraforaminal area? That means it's in the cranial part of the foramen. Then we have to address that. For example, SAP impingement. Or is it in the course of the axial nerve root? If we have osteophytes in the course of the nerve root, mainly in the lateral part of the foramen. So then additionally there are rare cases of Z-joint cysts which may be in the foraminal area. So example for that, foraminal stenosis, SAP impingement on the right side. That means by flexion or extension, the patient, especially when he puts his lumbar spine into lordosis, gets a radicular pain due to the impingement of the SAP, tip of the SAP, to the exiting nerve root. So what we do is then to resect with a deflectable burr the tip of the SAP, and it is important not only to resect the lateral part, but also the medial part to make the complete area free. So here on the right side we find the L4 nerve root, and that's the entry to the spinal canal, and the situation after resection of the tip of the SAP. Extrafemoral stenosis due to anterior osteophytes. Again, the exiting nerve root, you see the osteophyte here, which compresses from the anterior aspect the nerve root. So then, again, we have different tools to resect those osteophytes, like these automatic drills, diamond drills, or manual drills, whatever you want to use. Of course, we have narrow conditions here. It's the second possibility where we use the decompression of the foraminal area in case of stenosis. And the third one is extraspinal located Z-joint cyst. Here, L5 is one on the right side. You see the cyst here. You see the L5 nerve root directly below the cyst. So we open the cyst and then resect all parts of the cyst. And after clearing everything, some bloody content here in the cyst, we see the narrow conditions of L5 is 1 that we have. That means that's the caudal end of the L5 nerve root, cranial end of the L5 nerve root. And when we prepare this, we find the L5 pedicle here. Then we see the L5 nerve root leaving the foramen. So L5 pedicle, we have the L5 nerve root here, SAP, and then we find the S1 pedicle here, and that's the entry to the neuroforamen. So see how much space there is, nearly no space. So what's with foraminal approach in lateral recess stenosis? Well, the indication is absolutely limited because, first of all, we have to choose our approach as lateral as possible. Our pathology is the medial margin of the ascending facet. When you're choosing a posterolateral approach, you have to resect a lot of bone, which is responsible for stability when you want to reach this area. Then it is difficult to decompress anteriorly, and we have much more difficulties for mobility. And that's the reason why we normally have to resect in recess stenosis at least from the tip of the SAP to half of the caudal pedicle, and this is really hard to achieve with a foraminal approach. So we have limitations for the foraminal technique. We have to respect the axillary nerve root, especially when we're talking about, for example, endoscopic assisted fusion. We have to respect the anatomy. We have to look for the iliac crest, especially in lower lumbar levels. We are limited in mobility. We can gain mobility by using the drills, but this is also limited. We have no possibility to do good anterior decompression when we have hard structures, osteophytes, beside the disc level, and we have no possibilities to decompress structures from the posterior aspect. At the end, development goes on, and we have possibilities nowadays to work with navigation, electromagnetic navigation, and at the end of the talk I will just give you a short video of a colleague of mine who shows you in real time the use of navigation for a foraminal approach. And what are the advantages of this navigation? Well, first of all, you can use it during your learning curve. It reduces radiation, and it makes a very good intraoperative orientation. And so I think every new thing should be tried, and every surgeon who starts with this technique has to make his experience and has a new tool to work with this electromagnetic navigation system. Thank you very much, and have a nice day.